So welcome everyone to the 2023 Mental Health Stigma Roundtable discussion series. Today's roundtable, Roundtable 1, Understanding the Experience of Mental Health Stigma, is going to kick us off. I'd like to take a moment. However, my name is Jim Rodriguez, and I'm going to be the facilitator for this series and today's roundtable. I'd like to turn it over to Suzanne Feeney and David Minot. Suzanne from the New York State Office of Mental Health and David from Mental Health News Education to say a few words to get us started.
Thank you, Jim. Good afternoon. Thank you, everybody, for joining us today. We're very excited for today's roundtable. As Jim said, my name is Suzanne Feeney. I'm currently serving as Director of Program Management within the Office of Advocacy and Peer Support Services here at the New York State Office of Mental Health. I'm actually in our central office upstate in Albany. And I wanted to just share with you briefly that in support of our agency's strategic plan for statewide stigma reduction, we are collaborating with Mental Health News Education, and we're very pleased to be doing this. We started our strategic plan for statewide stigma reduction, and we envisioned it to be a major initiative spanning between 2 and 3 years. It was officially approved by our executive leadership in October of 2021. So we're about a year or say 15 months into our interventions and our measurement activities. Today is a very important milestone for us in that plan because, as Jim said, we are kicking off our series of roundtables specifically to dig into the topic of stigma. Mental Health News Education has helped us choose the panelists, which you'll all be hearing from today, and they've also helped us plan for another important milestone activity. That is the creation of the second special edition of Behavioral Health News. The second edition will be dedicated to stigma, and it will be entitled Stigma and How We Can Make a Difference. There will be more information coming out about that special edition, as well as a call for articles. We hope you'll be on the lookout for it, and we hope you feel comfortable contributing any content when that call for articles and that information comes out from Mental Health News Education. Thank you again for joining us today. David, please go ahead and add your comments.
Thanks, Suzanne. So my name is David Minot, as she said, and I'm the Executive Director of Mental Health News Education, the nonprofit organization that publishes behavioral health news and also autism spectrum news. Our mission is devoted to improving the lives and delivery of care for people living with mental illness, substance use disorder, and autism, while also supporting their families and the professional communities that serve them. And we do this by providing a trusted source of science-based education, information, advocacy, and quality resources. In addition, we provide a platform for our readership to communicate and discuss important social issues in an effort to reduce the harmful effects of stigma in the community. You can access our free library of over 2,500 educational articles in both publications by visiting mhne.org. And everything I say, I'll put in the chat for you to access. As Suzanne mentioned, part of this collaborative project is for us to publish 2 special stigma-focused issues of behavioral health news. The first issue was focused on understanding the impact of stigma and features over 25 quality articles written by experts on the subject. You can view the issue online by visiting behavioralhealthnews.org/archives and then click on the link for the summer 2022 issue. We will also post a link in the chat for that. The second stigma-focused issue of Behavioral Health News will be released in early April, and we'll be sending out a request for articles in the coming weeks. And now I'd like to introduce you to our roundtable facilitator, Jim Rodriguez.
Thank you, David. And as I've mentioned, my name is Jim Rodriguez, and I work at the NYU Silver School of Social Work at the McSilver Institute for Poverty Policy and Research, and it is my honor and privilege to facilitate this discussion. David, if you could pull up the slides, we're going to take care of a little housekeeping before we bring in our panelists. And as I mentioned, so this is the first of a series of roundtables. And just a few housekeeping and disclosure information. So as you're logging in, make sure that your full name is used. And we say that because we are offering CEs or CEUs for this series, not just today, but all of the roundtables that we're going to have in this series, the 4 of them. And that will help us to keep track of who attended. This roundtable is being recorded in many ways for educational purposes, and so others can see it. The recording and presentation slides will be available to view and download at a later date. Closed captioning is available, so if you have your Zoom screen on, in the lower banner, you'll see show captions. You can click that button. Click the show captions button, and if you don't see the button, click on the button with 3 dots where it says more on the bottom, and you should see captions there as well. And we'll have time at the end for questions and answers. So please, as the discussion goes, please enter your questions or comments into the chat as you think of them during the discussion, and we will address those questions or issues that you bring up during the course of the discussion at the end during our Q&A period. I also wanted to mention, just for your own viewing purposes, I suggest you go up to the upper right-hand corner where it says view, and I suggest that you select speaker view so that as people are speaking and sharing their stories, you will be able to see them and only them as they share. The other last thing, a quick disclosure, all panelists and planners for this educational activity have no financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients, excuse me. So, and then as I mentioned, there are continuing education credits available for each of these roundtable discussions, and they have been approved for peer specialists, physicians, psychologists, and social workers. They're only granted to those people watching the live presentation. So you all who are here live with us today will have an opportunity to get those CEUs. Unfortunately, they're not going to be available for people who just view the recording. You're required to attend the full 90-minute session presentation to qualify for the CEUs. And for those applying for CEUs, a survey will be emailed to you after the event. You have to complete that survey by the 19th of January to receive the CEUs. And your CEU certificates can be expected 1 to 2 months after the event. If you have any questions about this, you can email Karen Wagner about the CEUs at karen.wagner@omh.ny.gov. And then just a lay of the land in terms of following roundtables. Again, this issue of stigma is a complex and complicated issue. No way that we're going to be able to address all of the issues or factors surrounding mental health stigma in one 1.5 hour session. So we have broken this up into 4 roundtable discussions, and you see them here. The second roundtable in 2 weeks on January 26th is going to be the experience of mental health stigma among diverse groups. In the third roundtable, we're going to talk specifically about the role of the media in reducing stigma. And the last roundtable will include paths to reduce stigma and promote positive attitudes. And that roundtable will be folks from the various advocacy organizations that have been doing this work for many years to reduce stigma. And then to register for those additional roundtables, you can go to behavioralhealthnews.org/stigma roundtables. And then just a few guidelines for our discussion today. Type your questions into the chat, as we already mentioned during the panel discussion. Ask for information. If we use terms or jargon that's unclear, please feel free to chat in any comments that you have about jargon or information that we share that's not clear. Be open to alternative views. This issue of stigma, as I said, is very complicated, and it's also often controversial. There are many viewpoints. So certainly be open to alternative views and listening. Be comfortable with unfinished conversations, as we mentioned. That's why we broke this up into 4 sessions so that we can cover the issue in as many ways as possible, from a variety of angles as possible. So be comfortable with that. Practice self-care. The discussion around stigma can bring up stories and issues for you all, if you all in the audience might be affected or impacted by other people's story of stigma. That can oftentimes be very difficult for folks to share and for folks to listen. So please practice self-care, including taking a break, moving away, and if needed, connecting to 988 for support. Challenge respectfully. Again, you can do that in the chat, through the chat, and to each other as the panelists share. And feel free to share your experiences in the chat as we move forward, so we can hear not only the stories and the experiences of our panelists, but anyone in the audience as well. And then very quickly, I'm going to go through this very quickly just to sort of set the frame for our discussion today. First, a little bit about mental health stigma. And again, the definition of stigma. Stigma is a set of negative beliefs that people hold about another individual or group of individuals. That's a stigma, and that could apply to people from many groups. When we're talking about mental health stigma, that's a set of negative and often unfair prejudices about people who suffer from mental health conditions. And when we think about the impact of, this is just a small sample of the many ways in which mental illness impacts people. And just a few that I thought would help to frame our discussion. 46.6% of people will experience mental illness in their lifetime. Interestingly enough, so when you think about it, nearly half the population will experience some form of mental illness in their lifetime, which means this is an issue for everyone. And of course, for folks who have more severe mental illness, it can be it can be a very different issue. And so the degree and severity of mental illness can obviously differ, and that can also complicate the issue of stigma and deepen our understanding. Families of children with mental illness lose approximately $300,000 over their lifetime in terms of income. Individuals with serious mental illness earn a third less per year than those without mental illness. And individuals with mental illness have disproportionately higher mortality rates. So the seriousness of this issue is really underscored by that statistic alone. And then as we think about the various forms of stigma, the types of stigma, again, just to set the frame, there is public stigma. Those are the stereotypes, prejudices, and discrimination endorsed by the general population. It's sort of out there in the air that people walk around with. And as we talked about earlier, sometimes those are endorsed or reinforced by the media, but in other ways as well. But the public stigma is that's held by the general population. And then there's self-stigma, those negative attitudes. So, and these are often obviously related. So public stigma can lead to self-stigma, the negative attitudes of an individual to his or her own mental illness. It's also called internalized stigma. And then we have structural stigma, which is the prejudice and discrimination that is oftentimes encoded in policies and law, constitutional practices, again, also called institutionalized stigma. And then another form of stigma that is not oftentimes covered in the research and in the scholarship on stigma, but professional stigma. That's stigmatizing attitudes held by healthcare professionals towards consumers, or when healthcare professionals experience stigma from working with people with mental illness. So these are some of the forms of stigma, ways in which stigma plays out in the population. Next slide. And then the effects of mental health stigma, you can think about it broadly into two categories. There's the effects on the individuals, right? Negative belief about the self, as I mentioned before, self-stigma, low self-esteem and sense of self-efficacy, not seeking and staying in services oftentimes is an effect at the individual level, decreased quality of life, a worsening of symptoms. So, people who suffer from mental illness have their challenges, but stigma adds to that. And makes it worse for folks, or can make it worse. And then disempowerment, a failure to pursue life goals. And then there are the effects from society in general, blocked opportunities in the form of housing discrimination or job discrimination or discrimination in schools, social distancing and isolation, social exclusion, the not in my neighborhood syndrome, when you think about oftentimes putting services in certain communities, whether that's residential services or other community-based services that service people with mental illness, and then poor quality care, just the services that are available are not there or of poor quality. And lastly, over-policing and incarceration, as we hear oftentimes, this combination or conflation of mental illness with things like violence and delinquency or things like that can oftentimes lead to over-policing and incarceration. It's not often talked about as much in the literature, but certainly addressed often. Next slide. So with that as a backdrop, I want to move into our panelists, and I want you to meet the panelists. I'm going to introduce them very quickly. We have Nancy Craig Pierce, the Director of Community Systems and Systems Engagement at Families Together New York State. Emily Grossman, the Director at Coordinated Behavioral Care Training Institute. We have Maya Haley, a peer specialist, an implementation specialist and recovery trainer at the Center for Practice Innovations at Columbia University Psychiatry. And Larry Hochwald, the manager of the NYCPS Training Collective and Training and Technical Assistance Facilitator for New York City and Long Island, with the New York Association, NYCPS, the New York Association of Psychiatric Rehabilitation Services. And we have Taina Lang, who's the Chief Executive Officer, the CEO of Baltic Street AEH, Inc., and Ben Riker, Government Alliance Director with Velocity Bio Group. And so I want to turn to our panelists and thank them all for participating in this panel. And I'm going to start with a question just so everyone can hear and understand the impact of stigma on individuals. I'd like each participant to briefly share a little bit. I'm sorry, I should take a step back and say that all of our panelists, as you can see, have been doing work, have lived experience with mental illness themselves or their family members, but also work and have been working for many years addressing issues of mental illness and mental health and stigma. And so with that said, I want to just ask folks to introduce themselves, say a little bit about how you got into this work, and then if you can share with us your experience with mental health stigma. How has mental health stigma, any of those forms that we just talked about, have shown up in your life? And I'd like to start off and have Emily Grossman start us off.
All right. Thank you so much, Jim. And I really want to thank OMH and Mental Health News Education for asking me to be a part of this important panel today. I'm really thrilled and honored to be here. So I thought I would kind of combine the two questions because I think that's the best way to really address them for me. So I really started off in 1996. I was diagnosed with bipolar disorder. I was 18 at the time and was living at college. And I knew so little about mental illness, but the self-stigma was really there. I knew very little. The things I knew about mental illness, and I'm dating myself, there was a show, Beverly Hills 90210 in the 90s, where one of the characters, Emily Valentine, she was the girlfriend of one of the main characters, had a mental illness, and she was the one causing all the trouble. She burned the homecoming float. She was trouble. So anyway, these were the kinds of things I saw in the media, and that was how I felt about mental illness. I did not want to get treatment because I was afraid to be stigmatized, and I had a lot of self-stigma. Fast forwarding a little, as I was in treatment for mental illness and was hospitalized 12 times and nearly institutionalized for my mental illness. And so experienced a lot of structural or institutional stigma. The way I was treated by the police when I was taken into the hospital, the way the hospital, in both places, really feeling like I was a quote unquote, and I use this in very deep quotes, mental patient, and was not treated with the rights that I felt I deserved just as a human, And then I was able to make a full recovery and get into my first career, which was as a public school teacher. And that's when I experienced a lot of professional stigma. I did not want to come out about my own mental illness because I was working in a public school and very much did not feel like it was a really good idea to talk about my mental illness. I knew that I was in danger of losing my job or having a lot of bias if I did do that. So after this, I made the decision to get into mental health. A lot of my students were coming to me with mental health struggles, and I really wanted to help. And so I was trained as a peer provider, and I did that for a number of years before getting to combine two of my biggest passions. One is being an educator, and the other is being someone who is in recovery and really sharing that message of hope that people with mental illness can and do recover and live wonderful lives. And this stigma is what motivates me to do my work every day. I really want people to know my story and so many of the stories of my colleagues who have, and others who have really recovered and lived wonderful lives. We don't need a stigma like this when people with mental illness are doing amazing things in the world. And I wish that we could highlight that more. So I think I'm going to leave it there for now and pass it on to the next panelist.
Thank you, Emily, and for sharing all the various ways in which stigma has shown up in your life. I'd like to turn it over to Maya Haley now.
Well, thank you. Hi, everyone. I'm Maya Haley. I work as a peer specialist and recovery trainer, and I'm going to answer my question very similar to Emily and just combine the two. Stigma was what brought me to the work that I do. My career trajectory definitely started off with young people because that's where my mental health journey started. I was 12 years old, and my first diagnosis of major depressive disorder happened after I watched my grandmother, who raised me, have a heart attack in the apartment with me. And I went to school and I talked about it with our counselor. And the next thing I knew, I was being sent to a hospital because I was having really strong feelings about what I was going through. And I didn't know what to do with those feelings. And so that very quickly taught me not to talk about my mental health struggles or not to tell people things that would get me hospitalized because it was such an awful experience. But then to come back to school and have a conversation with my friends about being hospitalized, being diagnosed. Young people were generally at that time not equipped to have those conversations. I barely could, but I knew that it didn't feel like a safe space for me to talk. And so I kind of internalized all of that as something is wrong with me and something is broken inside of me. And I no longer on a fundamental level relate to any of the people around me, because who could relate to that experience, especially at that age. And so I started working with young people and moved throughout my career, which eventually brought me to peer specialist services and being able to be in a position to use my experiences and to advocate for ways that we can change the system, the ways we can change services, the ways that we can change engagement with people so that they don't feel like they are wrong for having feelings, whatever those feelings might be, and they're wrong for sharing them. So stigma is definitely what brought me to the work that I do, and it's what keeps me going. Being a peer specialist allowed me to run groups and have spaces where we could destigmatize, right, these conversations around mental health. And then when I was able to step into the position of being a trainer, I feel so fortunate to be able to do that and to be able to provide support to peer specialists who are experiencing stigma in their own roles and in their own personal lives. So stigma has brought me to this work, and stigma is what keeps me going, because it's all of our jobs to break it, not just peer specialists, not just people with diagnoses, all of us. So that would be the answer to that question, and I will pass it off to the next panelist.
Thank you, Maya. And I just want to key in on one thing you said, where you can destigmatize. I think, that's where it sounds like your work is really around that other piece, right? Struggling with mental illness and then the stigma adding to it. And it's by addressing stigma, you're addressing at least half, if not more, of the problem that folks struggle with. Thank you for sharing. I'd like to turn it over to Taina Lang now and share her experiences.
Hi, good afternoon, everyone. Thank you, Emily and Maya. Super inspiring to hear your stories. So I'm Taina Lang. I'm the CEO of Baltic Street Advocacy, Employment, and Housing, the largest peer-run organization in New York State. Proud to be doing this work now for a little over 20 years. And I think almost my entire life for advocacy. What brought me to this work are a number of things. First thing, I'm a child and the product of the 80s of the war on drugs, right? So I was the kid that lived in the housing projects that everybody's family member was affected by crack cocaine. I had personal family members that were utilizing the drugs, and I'm a Puerto Rican, so what happens in the home stays in the home, right? So, we didn't talk about what was going on at home. And what I didn't realize was that I was developing into a young woman that was being oppressed by so many microaggressions that almost exacerbated my depression in my lifetime, right? Of course, it doesn't come out until you're much older because we were taught and trained not to say what was going on within the household. So, I as an adult now, I realize that, there was public stigma. Of course, there institutional stigma with over-policing in these neighborhoods, in East Harlem in particularly. And something about not saying that you weren't feeling good wasn't okay, right? So finally, when I was strong enough to speak on, what was pretty much was breaking me inside, I was finally able to release it with my healing and recovery, actually starting this very work at Baltic Street. So, I didn't know that I was hurting. I didn't know that these things were just happening until I started getting and connected with the peers in this organization that was able to help me really realize, hey, listen, we really got to talk about what's going on, and what you're experiencing is historical discrimination and trauma. So it just really is what brings me to the forefront of ensuring that we continuously fight stigma, that we continuously fight all different levels of stigma, like as James, said earlier, even in my position, I still see stigma in my very own positioning now. And it's always about, ensuring that I tell my story and that I can hopefully inspire others, to be the voice, to find support, and to end, this critical part of ending mental health stigma across the world. And I'll pass it on to my next panelist.
Thank you, Taina. And I just want to quickly mention, I know, Taina, you're bringing up the issue of, your ethnicity and your background and where you came from and how that impacted you. Just a quick note to folks, the next roundtable is going to focus largely on the notion of multiple stigmas and stigma among various diverse groups. So I just want to sort of, as Taina is touching on the topic here, in Roundtable 2, we're going to talk more deeply around those issues. I want to turn it over to Nancy Craig Pierce. Nancy.
Hi, thanks, Jim. Hi, welcome, everyone. And I think I'm going to do what the panelists before me have done, because it's really hard to separate those two questions, how you got into the work. Because for me, I don't think it's work. It's a passion. It's a calling. It's what I had to do to help my family survive. So I got into this because I have 4 children, and my third child from birth was a little different. He had some quirks, and he had a lot of creativity, and he had a lot of complex challenges within himself. And those challenges, as children age, roll over into the community. And when he was about 5 or 6, he had a fascination with fire. And he also had a fascination with junk. So things came into our home that I don't know where he got them from as he aged. And he also had some sensory issues. So as we sought services, which we discovered there wasn't any, and we sought providers who could help us understand and help him and get us whole again. The system just was not set up for working on more than one thing at one time. And of course, you know, he's all of those things wrapped in that, plus our family. We have a family of 5, and he had siblings that, you know, needed help and understanding, and we didn't have that impact that we had on our community where we were shunned. In effect, we grew up in a very small, rural, Western county on the shores of Lake Ontario, and there wasn't others like us and had a child with those behaviors. And it got to the point in 3rd grade where the school said, he can't come here anymore. We don't know how to help him or you. And the other children were being stigmatized. We didn't have friends anymore. All of the kids' friends stopped coming around because of Ty's behavior and his quirkiness. We've had multiple hospitalizations throughout his life. He's a young adult now and continues to struggle with his diagnoses and with finding treatment that works around him as a person and not a disease. So I got into this work because others should not have gone through the struggles and the challenges that my family went through. How that helped is I found a very, very small advertisement in a local penny saver that said, "Are you concerned about your child's behavior?" I was like, "Oh Lord, yes, I have got a lot of concerns and no one can answer me," until I called this number and I spoke with another parent who was like me, who had a child that was struggling with mental health and didn't know where to turn. And we started a support group, and we found more parents that were like us. And we found more children who were like us, like ours, who were accepted with each other. And we weren't ostracized anymore. It got, the stigma was from myself. What did I do? It was a difficult pregnancy. Is there something I ate? Is there something I was too stressed? I should have done this. I should have done that. Then there was the community. I got into this job. I went to school, back to school, thinking I could become a social worker and I could solve our problems and I could help our family heal and move past this thing that no one really named. They just gave it diagnoses. And that didn't work. The professor, I had to leave school early, and the professor of the social work class gave me an F because she wouldn't let me take a pass or fail because of my child. And I thought to myself, oh my Lord, this is not a profession I want to be in. So I became a family advocate, a family peer, helping other families navigate this complex system and helping providers make a change in the world and how we treat families and we treat our young people. They are unique, and our families are unique. All families are unique. So the stigma that we had in our family, I think, Jim, you talked about self-stigma, you talked about the public stigma, professional stigma. When I mentioned to people that I help families navigate service systems, complex service systems for their children, the response is condescending. Oh, those parents need so much help, those poor kids. And what I come back with is that all families have strengths. All children, all people have strengths. And it's our job to find those strengths and to leave families with hope. So my hope of this forums that we're having these next three will leave people with hope that life gets better. So thank you very much, Jim, and David and OMH.
Thank you, Nancy. And I think it's just a reminder of how, mental health stigma is, as you said, naming it. I think distinguishing between naming this diagnosis or the symptoms of the problem and naming stigma and understanding that role, I think as Taina and Maya both addressed in their discussions. I also want to, sorry. Sorry about that. Just keeping time, and we're doing great on time. So I'd like to turn it over to our last panelist, Ben Riker.
Thanks. Hi, everybody. It's really great to be here. And I am just so grateful to have such an incredible panel, to be part of such an incredible panel. Yeah, my name's Ben Riker. Until about a week ago, I served as the director of policy at Friends of Recovery New York. And I'm now, as of this week, working in a consultation capacity on naloxone access across a whole bunch of Northeast, Mid-Atlantic, and Midwestern states, working on low barrier access to overdose reversal drugs. So new role for me. I came into the field really the last time I came out of inpatient substance use treatment. I'm a person in recovery from both substance use and several mental health disorders, diagnoses. And the day that I came out of inpatient substance use treatment for the last time, I landed by referral at I came home to where my parents where I grew up, and I landed, I got out about 10 o'clock and I landed at our local recovery community and outreach center, which didn't exist in the late 90s when I first started going in and out of substance use and mental health treatment programs. So 10 o'clock I got out. At noon, I was in a mutual aid group with a whole bunch of people who were navigating or had successfully navigated that system of care that I was had not had any success in for almost 2 decades. So I went on to get my CERPA, Certified Recovery Peer Advocate certification, and my Certified Peer Specialist certification, and eventually became a community education and outreach coordinator. And then I went on to work at For New York, overseeing our statewide youth program, Youth Voices Matter, which works closely with families together. And then on to the director of public policy position. And all of the work that we do, all the trainings we deliver and develop, stigma is at the core of all of the work. Stigma has a tendency to, even the language that we use, to really have an incredible impact on public policy that we don't necessarily recognize as it's happening. In my own experience, I suppose, Emily talked about her experience with police officers, and I certainly had that experience. I also had really traumatizing experiences in emergency departments and in inpatient mental health and substance use programs, from intake to discharge. Some really appalling, traumatic experiences. I guess the way that it impacted me the most, the way that has, in hindsight, that was the most, I guess, stigma created barriers for me, and it came generally from the people who love me the most and intended no harm. It came from my parents, who sort of, in thinking that they were helping, took away any autonomy I had around choice, around what pathway either my substance use or mental health recovery would follow. It pigeonholed me into a person who is really just kind of a shadow of everyone's biases around me. So it created these perceived barriers in my life, and I think it hindered my ability to do well. I participated in dozens and dozens and dozens of both substance use and mental health treatment programs that I had no say in. I had no autonomy. I had no choice. And it was really to appease the biases of my family, which were, I think at the time, well-intended. But I think as far as having a successful recovery, is building a successful program of recovery in my own life, it took me a lot longer than it should have, really based on the stigma of the people closest to me and the biases of the people closest to me. So I'm really happy to be here again. I'm just like so enamored with my co-panelists and facilitators. So it's great to be here.
Yeah. Thank you, Ben. And again, I stress this because I think it's so. A theme that I'm hearing from all of you is that, again, through your struggles, what the stigma does is it doesn't allow you to just be. You're defined by the problems and the difficulties and the challenges that you face, and that's it. And there's no opportunities or place to be just who you are. Which
James,
is
could I just say quickly that Tina mentioned something the other day that I found to be super profound, super simple and super profound, and in all the work I've done has never crossed my mind. And I want to acknowledge it because it's been on my mind since we spoke. And Tina had put in the chat that stigma is oppressive. And I thought those three words it was like revolutionary for me. And I just want to put it on the table because I hadn't made that connection. And it really, in one really simple sentence, sort of define my experience. And so I appreciate that, Tyne, and I want you to know that it literally has not left the forefront of my mind for days and days. So
well,
sorry for the interruption.
No. And I want to stick with you, Ben, because I'm going to transition into the next question, which is, the critical piece for all of us is what to do about it. And so I'm going to ask all the panelists. I'm going to start with you, Ben, actually. That as we think about stigma, it is oppressive, and I think oppression can sometimes just be in the air. It's sometimes baked into the DNA of society to other people, and there's many groups that are othered. What I wanted to sort of move into, though, is what has helped. And so what I want to ask everyone is what are the things that you think we need to do to either reduce stigma or minimize its impact on people's lives? I don't think we can ever completely eliminate it, but improve it. And I should also say, Ben, as well, what has helped you in your journey? So what do you think we need to do? What has helped you in your journey?
So this is really kind of easy for me, and I'm going to use sort of an anecdotal example. I spoke about my journey to recovery really started in a community-based program in Oneonta, New York, where I still live now and I still participate in programming. But they host all kinds of amazing programs. So they have a yoga class on Saturday mornings. It's open to the public, and all their programming is open to the public, not just people in substance use or mental health recovery. Anyone's welcome. And they're the same teachers that teach yoga at our kind of expensive, fancy yoga centers, and it's free and everything's free. And the most incredible experiences for me, both in early recovery and today, are those Saturday mornings. I shouldn't do yoga. I have no business flopping around in public doing yoga, but I do, and I love it. And those Saturday mornings when there's an open yoga class, and that room has 14, 15, 18 or 20 people in it, no one knows if the person next to them is a person in recovery or not. We leave and we go get milkshakes, or we go, we exchange numbers and we get coffee during the week, or our kids play together on sports teams, or whatever those situations are. And that experience of sharing, a yoga class, or, they host Adulting 101, how to balance your checkbook and open a checking account. Those kinds of experiences, being in those rooms with folks who, if you under any circumstance you wouldn't recognize as a person in recovery or not, are profound, right? We have people, you can watch the light bulbs go on as people sort of self-disclose, and you can see the folks who aren't in recovery really sort of, I don't know if it's shock, but you can see the biases melt away because they've had interactions and would have never guessed. For me, those experiences, those community-based experiences, are the most profoundly revolutionary when it comes to stigma. And I wish, how do we get doctors in those rooms? How do we get providers in those rooms? How do we get teachers in those rooms? How do we get all those folks who don't recognize that they're sort of propagating stigma into those spaces where you can share time and energy and joy and all those things with a person with a diagnosis, right? So it's really simple for me. It's community-based experiences are profoundly impactful on perceptions and stigma and bias.
Thank you, Ben. I just want to give a quick note. Sylvia, I see your hand up and I see you. What I would ask is if you could put, for now, your question or comment in the chat and we'll hold it, or during question and answer, we'll be able to unmute you and have you share your question then. Thank you. To go back to our panel. So Emily, I'd like to sort of get your thoughts on, again, what do we do to minimize the impact of stigma and what has helped you in your journey?
Sure, Jim. So interestingly, like Ben, my first answer, and we didn't really discuss our answers ahead of time, was inclusion. So Ben really covered that beautifully, but I also want to put in a plug for professional inclusion. I think that when more people at all levels of companies feel comfortable to come out, including CEOs, about their mental health struggles, that's when things start to normalize themselves. And I feel like we're moving in that direction very, very slowly, but I really hope that it continues. Another big thing is common people coming out about their mental health struggles, and behavioral health struggles, just as we're doing today. Dr. Patrick Corrigan, who is a director of the Chicago Consortium for Stigma Research and an amazing presenter in his own right, really talks about research that they've done about how when common people come out, not celebrities, but when we come out in droves and share about our own stories, that's really a big and important piece of destigmatization. And just to share a little anecdote from my own life, I started to feel comfortable in my own skin around diagnosis when I started to speak on a volunteer basis for NAMI and in a program called In Our Own Voice. And that happened in New Jersey, but it's all over the country. And I remember my trainer at the time, a man by the name of Robin Cunningham, was a man who had lived with schizophrenia and was out about his diagnosis and was also a CFO of several Fortune 500 companies. And when I saw someone in a position where they had succeeded in life, that was my first experience seeing someone who had succeeded in life with a mental health struggle. And that really gave me a lot of hope. So I try to be a beacon of hope for others because of that. And the last one I'll say is the media. It's my hope that the media learns how to report on us responsibly, because it's not happening now. And without getting on a soapbox about that, I think that's a very, very important in our media-driven society. That's very, very important. So those are some of my comments about what helps.
Thank you, Emily. And thank you for that plug, because in the third roundtable, the third roundtable discussion, we're actually going to be talking about that. And we're actually going to focus that roundtable discussion on the things that media can do to help. I think we all know the things that the media currently does that don't help or that hurt. But we're going to talk a lot more about what the media can do to help. I'd like to turn it over to Maya and share your experiences. What's helped? What do we need to do to improve?
Yeah, thank you. So when I was thinking about this question, I thought about how talking is not enough, right? Like we talk about talking and normalizing, and I think that there are conversations absolutely happening. But I also think that to have a conversation and not to have that open-mindedness is doing a disservice. No matter if you yourself are struggling with mental health, if you're trying to support somebody with mental health, I think just making that commitment to being open-minded to somebody else's experiences and perspectives and not villainizing them for that, right? Like, it is not our fault we are struggling. We are not choosing to struggle. So many of us still use this language of, I wish I were normal, or that I had a normal brain. But why do we even have those thoughts? It's because of this stigma that, again, something is wrong with you if you have a mental health challenge or a diagnosis. So I think that making space for people to talk about their experiences and to not be afraid of those experiences. I know my friends were very afraid of hearing that I not only wanted to kill myself, but was actively engaging in self-harm. They had no idea what to do with that. And I had no idea how to have those conversations. But I think the earlier we start to talk to people about mental health and normalizing it, and even taking it to the other end of the spectrum, whether there's people who have been in mental health services for years and years and years, addressing everyone as an individual, right? Seeing past their diagnosis and allowing them to really be a full-bodied person, because we are. Yes, our diagnosis is a part of our life, and yes, it is a part of our struggles, and that's just a part of the story. And the really important part is that we have people who are willing to support us. And the only way we can get that support really is if we have the space to be heard, and not just like, oh, well, we let you talk. No, I heard what you said, and I hear how I can help, and asking questions, because a lot of times people don't necessarily know how to support us. And instead of kind of internalizing that as a feeling of helplessness, just asking if there is anything that I can do, because maybe I don't need you to be my therapist, but maybe we can go to a painting class next week so that I can get out of my space and get out of this mindset and just be with people. So just kind of centering people as not their diagnosis, as more than their diagnosis, as more than whatever symptoms they have. And again, that open-mindedness.
Thank you, Maya. I'm going to turn it over to Nancy. Your thoughts.
Okay. Well, Maya, you were right on, right? If we talk about it in an open space, and in my case, I had to make a decision that was going to throw off a cloak. The oppression is perfect analogy. In my world, it was this heavy wool cloak that I wore, and that weighed down our family, and it was black. It just kept getting darker, like you were in a dark tunnel. And so one day I decided that if we were going to move forward as a family and heal all of those things, every hospitalization was a stigma. Every time his placement in a residential for a number of residentials and a number of years. And again, he's a young adult now, middle adult, I guess, like 30. So we don't do that anymore, thank God, because of the work that we have and what we know, right? We didn't know what we didn't know back then, but we know better now. So when I decided to throw off that cloak, and this is what I hope families understand, take it away, stop isolating yourself. Call it by name. I did a newspaper in my early career, a newspaper article when children's mental health started. And it came out, it was a Sunday feature, it was above the fold on it was actually the whole front page of the lifestyle section. And when my mother opened the paper, I could have sworn I heard her scream, because I used our town and I used our name. So when Ben talked about family, my siblings didn't understand until their children got older, and we didn't have rites of passage. So when I look at stigma, we built a community of acceptance within ourselves, and now we need to open the doors to make a community of acceptance across the world. If we look, Jim quoted, almost half of this population in the world has some type of mental health challenge. So why do we feel like we have to be in the shadows? We are almost the majority, people with mental health challenges and their families. So, one of the things, stigma It's a terrible thing, but it made me strong. It made our family strong. It taught us things that we didn't know we needed to know, and maybe I didn't want to know, but I had to know. And so for me, the stigma that our family suffered made us whole. And it made us change the system. That's what stigma can do if we wear it into not as a cloak, not as an oppression, but if we wear it, I always like to think of it as a tiara. I'm wearing it as a tiara. So for me, that's what stigma needs to, how we can overcome stigma. Thank you.
Thank you, Nancy. Changing the narrative, literally flipping the narrative in many ways, as you're suggesting. How do we get there is the other challenge, but the need. And then Taina.
My heart is so full right now with all of the testimonies. I just have to say quickly, thank you for that, Nancy. I'm just like, right now, I don't want to get choked up either. So a couple of things that I jotted down that I thought was extremely helpful when we want to, eradicate stigma. Number one is adjust your thinking. Instead of wondering what's wrong with the person, try reframing that and saying what happened to you, right? It changes the narrative in just that very simple question. Understanding that how a person, don't devalue a person's life experience with mental health. Be open to the idea that someone has experienced life differently than you, right? Because I think that that's also a really big thing that we need to talk about. Choose your words, language carefully. What we say and how we say it matters. Making small changes to how we talk about mental health in general can go a long way to decrease stigma. Things like stop saying things are crazy, right? I mean, because that's just like the common language, right? Or stop overutilizing the word bipolar, like this person is bipolar. Like it is oppressive. Let's stop that kind of language. And how we talk about our participants or the individuals that we service is a huge reflection of how you are providing services to that individual if you're in the service field. Okay, so let's remember, this is a person that is seeking support. You are there to support a person. So ensure that you are giving supports. And if you start slipping into negative languages, then you need to do a real self check on yourself, because it's a reflection of you, of not the person. Okay. And I've seen that in my career, and I've checked a lot of people in my, even in current and surrounding organizations about language. And remember that people are more than just their diagnosis. We are all complex individuals, right? I'm not expecting people to say, hi, I'm so-and-so and I have schizophrenia. That's not so, right? You are a mother or father, a sister or brother. You're an active member in the community. We are very complex other than mental health diagnoses. And educate yourselves and others about mental health, right? I think that that's always going to be a catalyst. If you even hear an earshot people utilizing language that is incorrect, I would impose for you to be brave and to address and how you can reframe that person's thinking and, take that time to make it an educational moment. And of course, last but not least, please show compassion and dignity, because everyone deserves compassion and dignity at all levels, and definitely empathy, empathy without judgment. And that just goes for all walks of life. And if you are a service provider, I have to throw this in there. At any given moment that you're feeling that your empathy is being compromised, please, please, please utilize your supervisions in order to address that, because you might be experiencing burnout. So take a vacation, take a mental health day, regroup yourself, and those are all the things that I would feel that can help and change the world around stigma.
Thank you, Taina. And so, Larry, I just wanted to bring you in here. Larry, I know you in your role, you've done a lot of work and worked in a number of different work groups and groups that are focused on this question of what we need to do to reduce stigma. So I wanted to ask you, in terms of, those experiences that you've had, what is the main takeaway? If you could briefly just share with us, what is the main takeaway that work has led you to conclude are really important pieces of stigma reduction?
So thank you, Jim. It's an honor to be a part of this panel, but I know I got to talk fast. So, I was brought into stigma in a whole different way. I was brought in, I worked for a large system. We had a large residential system. And when we tried to build housing, we found that something I'd never heard of before, which was NIMBY, not in my backyard. So the director of our department told me, this is stigma, find out about stigma and end stigma. And then, spoiler alert, I was not able to do that. But we're doing it here today. In my research, the big takeaway, and we did a report for the city years ago, was people need to get out there. People need to communicate. There are all these so many misunderstandings and misconceptions about who our community is and the only way to combat that studies have shown is all the things everybody mentioned here: getting out to communities, talking at community meetings, speaking in the voice, our own voice, add our own voices, all the different things that were mentioned. That's the solution. The problem we had, we tried to get people to go to community meetings and all, is that our system for many years, not anymore, fortunately, people's families, all the well-meaning people in their lives, we're trying to get them to do the complete opposite. Don't talk about it. Don't go out there. So things like what we are doing here, what all of you guys are doing, what OMH and Behavioral Health News and Jim, what you guys are doing, this is how we can change and stigma. So I hope it's hopeful. We haven't moved the needle much in all the years I've been doing it, but it's hopeful that this is the start of something really great. So thank you, guys.
Thank you, Larry. And I think I want to sort of turn it over to our researchers now. So we have two folks who've been doing a lot of work in this, but I wanted to highlight, Larry, what you said that's so critically important is that things have changed. I think now seeing, and somebody talked about this earlier, it's not enough to get the celebrities and folks out there who are talking about their experiences, because that is completely oftentimes untied to the experiences of people out there every day who struggle with this. But we do see that conversation, that narrative increasing now, and an increasing understanding of mental illness and its broad impact on people in society. But yes, and I think the issue of those who have more severe difficulties and severe challenges are there. So I wanted to turn over to we have two researchers and two folks who've been doing a lot of research and thinking about stigma for many, many years, Phil Llanos and Marilena Lecas. And I want to give them an opportunity to respond to what we've heard. We're going to get to question and answers from the audience in a few minutes, but I just want to give our researchers a chance to sort of share their thoughts based on what they've heard. And Phil Llanos, I'd like to start with you.
Sure, thanks so much. So what I just did was I was paying attention to what folks were saying, and I was noting how consistent it is with what we know about stigma and the forms of it, and what is effective in terms of overcoming it. So I just wanted to note some of those things. So we heard Nancy talk about something that she didn't name, but it's what we call associative or courtesy stigma, right? Which is when stigma affects not just the person who might be labeled, but people who are close to that person, who are in their circle, right? And that can, of course, affect family members, but can also relate to professionals. And I've done some research on, how professionals are affected by this type of associative stigma as well. We heard Ben talk about something that he didn't name, but that I would call microaggressions, experiencing it from family members, even though, well-meaning, sort of being treated kind of like a child or dismissed, even though it was coming from a place of love, but it's still being something that affected him negatively. We heard Emily at the beginning talk about how media stigma impacted the views that she had about what mental illness was like. And this impacted her as soon as she had an inkling that it might relate to her, right? So the views that she saw on, Beverly Hills 90210, that was her image. And so now it's like, oh, I'm that person, the person who's causing all this trouble. And that's what we call this bit modified labeling theory, which is where, we absorb these ideas about what it means to have mental illness through the socialization process. Nobody's directly teaching it to us. And then we sort of imagine that's what people think about us, when we're diagnosed. We also heard about professional stigma from, I think Emily, Maya, and Taina all talked about it to some extent, and how professionals can enact stigma as well. And this is an important area that I've studied a little bit. In terms of ways to overcome stigma, we heard a lot of emphasis on contact from Ben. We heard about kind of collaborative engagement in a task, and that goes back to Gordon Elport's discussions about, equal status, contact, shared activity. And then also just disclosure, right? We heard about that from Emily and Maya, and how important it is for the person who discloses to be somebody who's credible, somebody you can relate to. And that's very consistent with what Pat Corrigan has talked about. So those were all things that were very connected. Something I just want to point out is that I also heard these themes about, stigma being kind of a motivator for activism, and so I was really struck by Maya's statement, stigma, keeps me going. And then we also heard similarly from Nancy, stigma made me strong, and so, I wanted to just say that, of course we're talking about stigma, but I didn't hear people talking about mental illness symptoms being the main focus. I heard them talking about how stigma was really energized them to take action in their careers. And, this is important because peer support, of course, many of the folks on the panel are involved in peer support. Taina is running a large, peer-directed agency. Maya and Emily are involved in it as well. And I just wanted to say, the peer movement is really what brought stigma to the radar of the professional system. And internalized stigma, what we call internalized stigma or self-stigma, really came from the peer movement. So I just wanted to read a couple of quotes. So from Judy Chamberlain's book in 1978, On Our Own, she said, group members, she's talking about the early ex-patients movement groups, group members began to recognize a pattern they referred to as mentalism, insane chauvinism, a set of assumptions which most people seem to hold about mental patients, that they were incompetent, unable to do things for themselves, constantly in need of supervision and assistance, unpredictable, likely to be violent and irrational, so forth. Not only the general public expressed mentalist ideas is what she used, the term she used, so did ex-patients themselves. These crippling stereotypes became recognized as a form of internalized oppression. So at the time, the term internalized oppression was used, but it's the same idea, self-stigma, internalized oppression. And this is something that motivates people to take action. The peer movement has been instrumental in changing the discussion as well. So this is a quote from Sherry Mead. Peer support interventions offer a culture of health and ability as opposed to a culture of illness and disability. The primary goal is to responsibly challenge the assumptions about mental illnesses and at the same time to validate the individual for whom they really are and where they have come from. So that's what I wanted to just say in terms of my reflection on all I've heard and how important it is for us to use our anger to energize us into activism and helping others.
Thank you, Phil. And Marilena Lecas, please share your thoughts.
First of all, thank you, everyone. I was really humbled by the powerful stories. And what struck me first was that all of you, all the panelists, spoke about exposure to different forms of stigma. It's never just, I've experienced self-stigma, which is internalized, but it's also anticipated stigma. I expect to be stigmatized, and therefore I do not attend services, which is something that Emily started discussing. But you've also spoke about institutional stigma, bringing in the police, but also institutions where mental health services are provided and they're supposed to help people with mental health conditions. That is very powerful. And in my work, that for me is a critical space where we can begin to truly change things. And you also spoke very eloquently, all of you, about professional stigma. And I think what I heard when Phil and all of you were talking about the power of disclosing to peers and feeling the complete acceptance of who you are by peers is what we fail to recognize is that people with mental health challenges or conditions or symptoms or whatever language you want to use, and we can talk about language as well, are experts of their own lives. So when we discussed what can be done, I really appreciated Maya's comment about ask questions. If you don't know how to support us, ask questions. The other thing that really struck me is what Ben said about stigma being built into policy. And that is very important because Larry spoke about not in my backyard, not wanting a clinic, not wanting a residential facility in my neighborhood because it's going to decrease property values, right? These are all stigmatizing actions and behaviors that are built into policy. And what happens and why this is very powerful is because they often go undiagnosed, if you will, misrecognized, and affect people's lives surreptitiously. So one of the things I want to emphasize is what you all spoke about. You spoke about institutional and structural stigma. So stigma goes beyond labeling, right? It goes beyond saying us and them. It goes beyond stereotyping. It goes into what you all spoke about, which is oppression. And oppression is forms of excluding people from opportunities, excluding people from housing, not hiring people for jobs. You have all accomplished, all the panelists have accomplished wonderful things professionally, but truly stigma acts as a barrier. When we were discussing about what can be done, you all emphasize the power of education, but primarily contact. Coming in touch with people that have mental health conditions and normalizing, the whole diagnosis thing. And what I was struck also by was Nancy's comment about, I believe you used the word cloak and hiding and isolating and non-disclosure, the opposite of what Phil mentioned. And it's very powerful. And I think stigma affects people in ways that undermines their well-being because people internalize stigma, anticipate being stigmatized, and do not access services. And there's a lot of research on that. More than half of people with mental health conditions report that I'm not accessing services because I anticipate stigma. And unfortunately, they anticipate stigmatizing attitudes and behavior by mental health professionals as well. So in that vein, I want to applaud OMH's attempt to assess stigma in their own facilities, assess stigma among mental health providers. If you look at the stigma research, most of the research is about the public and folks with mental health conditions. We are shying away from looking at stigma among mental health professionals as much as we should. And I think that's a critical point. And finally, I want to talk about a comment that Larry made about silence. And it reminded me, I'm going to date myself, it reminded me of the beginning of the AIDS epidemic, where the LGBTQ plus community came out with a sticker that said silence equals death. And I think what we're doing today and the other 3 roundtables that are going to take place are anti-stigma, are stigma reducing efforts. And I'll stop there. And I'm honored to be part of this effort.
Thank you, Maria, and thank you, Phil. And I'm glad you brought in that last point, Maria, about the AIDS epidemic and the stigma around that, because I think there's many lessons learned from that. And I think one of the things that came out of the AIDS epidemic was this idea that there were many different ways the community had many different ways of approaching it, right? There was protest, there was really in-your-face protest, things like, silence equals death. But there was a lot of work going on in the background with policymakers and with our public health system, right? And conversations going on in a lot of different ways. But the bottom line is everyone agreed, as long as it's addressing stigma and reducing stigma and bringing services to folks who are impacted by HIV/AIDS, it's on the table, right? Everything's on the table. So I want to turn it over to our Q&A, and we've had questions come in. So I'm going to kind of bring some of those questions in. And Sylvia, I know you had your hand up, so I'm going to start with yours. And this is for the panel. If anyone wants to, you've kind of addressed this. We've talked a little bit about what you can reduce stigma, but who do you seek? And this is for anyone on the panel, but folks who've already addressed, who do you seek for help when dealing with stigma? I guess if I can sort of say it from Sylvia, right? Like, who's your go-to person? Who do you go to seek help when you're dealing with stigma specifically? Which is an interesting question, as we talked about, right? I'm hearing not so much your symptoms and the difficulties that you're facing, but with stigma specifically. Does anyone want to respond to that?
Can I respond, Sylvia?
Oh, sure. I'm sorry, Sylvia. Yeah, sure. You're unmiked and speaking. Yes, please share.
Well, I seek from help from Tina Yeri. She's from Strive, another program that helps people with mental health and disabilities. And what I notice is that when she runs the support groups, that it's very beneficial, like, to know that you're not alone. You're not dealing with this alone. There are other people that, like you said, we're the majority. We're not like a small spectrum of people with dealing with this issue. So that's very important, at least in my opinion.
Thank you, Sylvia. Thank you, Sylvia. And anyone on our panel want to respond? And again, I've heard this very strong theme of peer support, and support groups have been very helpful. Anyone else?
This is Nancy. I think one of the things is that, Maya, you say this all the time, is that you call it out. You stop it in its tracks, right? Stigma can only grow when we give it power. And by calling it out or saying, that wasn't very nice, or that's really not what that is, and correcting people as they make, we have to stop hiding in the shadow and accepting when about stigma. So anything, we don't like language. We call people out on language all the time. This is just like language. It's normal to say, that wasn't very nice. I have a child, or I have a mental health symptoms, and we don't call ourselves crazy. I can call me crazy. You can't call me crazy, right? So we call people out, and that brings it into the world. That corrects someone in a polite, respectful manner. That's what I do now.
Thank you, Nancy. I want to make sure that we get to a number of questions. So I want to say that another question that came in from Yogesh Kumar. I hope I pronounced that name correctly. But Yogesh asks, can we work on bringing awareness on social media to accept mental issues as a normal part of life, not stigma? And so I don't know who wants to try to speak to that. Yogesh, I also want to mention for everyone, for the audience, in our third panel that's going to talk about media, we actually are going to have someone who can talk specifically about social media messaging and the power of that in reducing stigma. But does anyone on the panel have thoughts about that? What do we know about social media messaging and what that can do to reduce stigma?
I can jump in here. So I remember, and I'm a little older, so I remember when I first came out on MySpace about my own mental health challenges, and I was very, very anxious about it, but I knew that I needed to do something to do my part to destigmatize. And I was overwhelmed by the positive support. And so I do make a practice of putting it out there on social media, most recently on LinkedIn, because I think that professionally, we need to let people know that people with mental illness are working in professional roles. And so I think that social media is it's one of the positive things about social media is that it can be a destigmatization tool.
I'm gonna hop in and
anyone, I'm sorry, yeah, go ahead,
yeah,
Tina.
I was just gonna hop in and agree with Emily's statement. You know, I mean, the people that are in charge of social media are those that are behind the keyboard, right? And we have all learned about what not to do regarding stigma. So I would challenge you all that if you have social media, get on a post today and say what you've learned today from this amazing roundtable, and say, you know, you're going to make a commitment to anti-stigma work surrounding mental health. I mean, that alone, start a conversation, it goes a long way.
Yeah. Oh, you know, and Jim, one more quick thought. You reach younger audiences often with social media, and you know, studies have shown education programs weren't really changing people's minds, but you can have an impact when you're reaching people young enough that they haven't been swarmed with all the negative and false things. You know, getting these things into the schools is another way that we've been fighting for years. So social media reaches that same audience, and you really need to, you know, you see how tough it is to get anti-racism stuff in the schools. So this is not an easy ask across the country, but some states like ours, we can do a better job than maybe, you know, it's going to happen faster here than other places.
Yeah. Thank you, Larry. I want to move on unless anyone has something really hot they want to add. I want to move on to another question. I want to, this kind of question comes up too, because I think it comes to the issue. So Bernard Nenner asks, can you comment or discuss the stigma between two individuals, one having mental illness, which was hereditary, and the other developing it through chronic substance abuse? I don't want to impose more on what Bernard is asking. So Bernard, if you want to unmute yourself and clarify, but I think there's this issue oftentimes of, as we have this discussion about mental health stigma and mental illness, that yes, it is common, as we've already kind of established, it is common. And yet there are differences oftentimes, right, among people or among the group of people who suffer from mental illness around severity, around comorbidity, and those kinds of issues. I wonder if anyone wants to sort of take a stab at addressing that question. And Bernard, if you have anything that you want to clarify with regards to that, please raise your hand.
So I'll take a stab. I don't know how. There's two pieces. First, as a person who is in recovery from both mental health and substance use diagnoses, that there is some self-stigma that we engage in, sort of in support of our own egos, right? Like, I'm not as bad as they are. You know, I struggle from substance use rather than a severe mental health disorder, or vice versa. So I think a lot of that is driven by self-stigma. A lot of that is driven by our protectionism, right? Finding our place. Where do we belong on the continuum? You know, do we belong in SUD treatment? Do we belong in? And there's barriers to that. I mean, dozens and dozens and dozens of people I've worked with, I've been unable to secure a bed in a mental health facility because of an underlying substance use issue that they have to deal with first, or vice versa, unable to secure a bed in a mental health facility, or the opposite. The second piece I just need to address, because there's an incredible, we talked about language, and there's an incredible study, Dr. John Kelly at Harvard Med Recovery Research Institute in partnership with Mass General, has this incredible study on language. And I want to put this out there only because I recognize, I hear the term abuse in the question, and this isn't a judgment, it's just an opportunity to share. He did an incredible study on language, asking many hundreds of people, does a substance abuser deserve punitive jail? Do they deserve jail or treatment? Upwards of 70% of respondents said that if you're a substance abuser or an addict, you deserve jail, you deserve punitive treatment. When they asked the same question, does a person with a substance use disorder rather than addict or substance abuser, deserve treatment or jail, the respondents flipped. It was almost 70% said that person deserves treatment. So I just want to address the use of the word abuse. We see it a lot in clinical settings. We don't anymore in peer-based settings. So I want to encourage everybody to be cognizant of first-person language, just because it goes back to how policy is driven, it goes back to how perception is driven, and just those really simple changes in language can affect policy, can affect outcomes, and can affect treatment of individuals in the day-to-day. So that would be my kind of probably not complete answer, but.
No, but again, great. Thank you for sharing that, Ben, and a great example of a wonderful example of the use of language and what a difference it can make. I want to actually, this one question that comes up, and I guess it's really appropriate to maybe bring up to actually Suzanne. Because Irina Kramkova says, what is the role of policymakers and government officials in addressing mental health stigma and supporting mental health initiatives? And so I wanted to bring you, certainly, actually, I'm sorry, I should broaden that out to anyone on the panel who can address that issue. But I think Suzanne might have thoughts about that with regards to the initiative that she's currently championing. But actually, first, anyone on the panel want to sort of put their thoughts about, because Susan is here and listening, about what policymakers can do?
Jim, it's Nan, and I just had to jump in. That's what I've been doing for 30 years. I can't break that again. Can't break that habit. One of the things that I want to say thank you to the Office of Mental Health for is for always, in the last 30 years, I wouldn't be in the position I have today. I wouldn't have the life that we have without the Office of Mental Health being able to say, I want to listen. I don't know if I can change things, but I want to listen. So for 30 years, you have listened. The Office of Mental Health has listened. They're a little slow to make change. Got to say that. We all know bureaucracy moves at the less than a slug. But the opportunity to say, this is what I need today to help my family, and this is what I need tomorrow. And then more importantly, to listen to the young people about what they need now so that they do not impact the system any more than what they have already, so that they heal faster and they're stronger than the generation before. So first off, thank you to the Office of Mental Health for listening. I just think we need to listen more. We need to have more of these kind of opportunities for families and to share, for families and all people to share, community to share. I don't think we listen to the community well enough about what their fears are, because that's who we have to change the mind to. That's who we have to change. So thank you. And that I'll stop now, but I just couldn't resist to say thank you to OMH. And all of the systems. We just need to do more.
Thank you, Nancy. Anyone want to say one last word, because I want to make sure we get on time? Yes, please.
I'm just gonna hop in as well. I think one thing too, as a policymaker, there should be biases training to the policymakers, that before developing policies, please check your biases, because I think that while we're at the table, we're not really thinking of the bigger scope at times, and we might come from a more of internalized stigma while developing the policy. So we want to make sure that we're avoiding those things.
You know, Taina, I'll give you the last word, and Suzanne, I know you'll be on these panels and available to respond to folks. David, we're gonna transition out to make sure that we're respectful of people's time. So just a couple of quick notes. We do have some resources available for folks. So to register and learn about the upcoming roundtables, you can click on that link. I believe David is putting the link in. So please, it'll be important to attend as much as possible all of these roundtables to get a full 360-degree view of the issue. The special issue in behavioral health news, understanding the impact of mental health stigma, is there. already, and I really encourage you. The stories were amazing and very accessible, easy to read and clear. And then, of course, you can visit the New York State Office of Mental Health Resources to get more information, publications and information about mental health stigma. And then just a quick shout out for our next roundtable. And these are some of the folks: the experience of mental health stigma among diverse groups. So we're going to continue to talk about this issue, but we're going to talk about, again, multiple identities. And so these are our, I won't go through the list of all of them because you'll be introduced to them in another week, but these are our panelists. And we're looking for just as much of a deep and nuanced understanding of mental health stigma from that roundtable crew. I want to thank everyone on who's joined us. I want to thank OMH and Mental Health News and Education for sponsoring this and promoting this. I want to thank our panelists and our researchers who've given their thoughts and input. Again, very much thank our panelists for sharing their stories and sharing their experiences. And lastly, I want to thank you, the audience, for joining us and bringing out your questions and participating in this roundtable discussion. And we look forward to seeing you in 2 weeks for roundtable number 2. Thank you all. Take care and continue to do this wonderful work that you all do.